Yeah, my name is Dr. Duke Bahn. I'm a board-certified radiologist practice in Ventura, California. I've been interested in prostate cancer early detection and proper staging, and then developing minimally invasive therapy option for the man who has prostate cancer for the last 15 years.
Dr. Bahn, you have been involved in the early introduction of several new techniques related to the diagnosis and treatment of prostate cancer. What do you think have been the most useful and appropriate of these techniques?
In general, transrectal ultrasound is the most important part of detecting prostate cancer, historically and also still it is, because most of the cancer is detected by ultrasound-guided biopsies. The question is, how do we detect prostate cancer properly and accurately? By using color Doppler, that is, looking at blood flow pattern in the prostate, including the abnormal area, we will have better information how and where to take a biopsy. By doing so, we could have a correct diagnosis and correct staging. That's the only way that someone can have a proper and well-educated decision as to the treatment option.
Are there any particularly new techniques, such as elastography, that you think are interesting?
It is quite interesting because it's been already used in breast cancer field quite extensively, and it will bring us better understanding in terms of the prostate cancer detection. Especially color Doppler is good but not perfect. Certainly grayscale ultrasound is useful but not perfect. We are adding another piece of information. So by combining all together, we may able to prostate cancer more accurately than the before.
Can you talk to us about the appropriate use of mapping biopsies today, most particularly related to the use of this technique to identify patients who may be candidates for focal cryotherapy or focal HIFU?
Let's go back to the so-called saturation mapping biopsy. It has a good option, but it has advantage and disadvantages. Advantage is that it can pick up more cancer, and then especially it is good to the man who had first or second negative biopsy, but PSs keep on going up. But the disadvantage is that, number one, it is very invasive. You need anesthesia and OR facility. And since they are taking about up to even 80 to 100 tissue cores, it could be very expensive. Because of the many cores were taken, it is associated with some side effect and complications. Those are some disadvantage. But my technique is that going after the cancer, number one, and also not only going after the cancer to find out what it is, what kind of nature it is, but also I take a biopsy from the nearby tissue to know whether or not the cancer is still contained within the prostate or already out of capture. We call it staging. It is the most important information when you consider a treatment option.
Are you performing minimally invasive cryotherapy to a single part or a single lobe of the prostate?
Right now, I've been doing more focal cryo than total cryo, because you know that the demographic has changed. As you know, with the popularity of PSAs, we may pick up cancer too many unnecessarily. And then those men end up with the radical treatment unnecessarily and end up with suffering from a quality of life issue. So then question is that what we're going to do about this many men with a low risk disease. Some of the men would not be comfortable with staying on active surveillance, but they're also not comfortable with doing something radical, whether it is surgery, radiation, or hormone therapy. In that case, I believe that focal cryosurgery is good compromise, good middle ground. So That's why it gained quite a popularity lately.
What percentage of your patients go on to active surveillance or similar expectant management protocols today? Are you seeing an increased willingness of appropriate patients to accept such management?
It's so difficult to answer because of the most of my patients coming to me as a second opinion. All right, so they already been on active surveillance or already been treated already, so I have no control of that. But actually, still in my practice, quite a few number. I would say more than 400 men is undergoing active surveillance program.
In regard to high-intensity focal ultrasound, how do you view this technique in determining when it is a beneficial option, particularly with respect to cryotherapy?
Well, HIFO has been around for a while already, but unfortunately, we didn't have any FDA approval in US. So it's been done out of the country, mainly Europe and Canada. It has a very good concept. I was quite interested from the beginning, but because of the availability issue in US, I was kind of a little bit shy away that because of the it takes lots of energies and other planning to do. So it is bottom line is that if candidate was carefully chosen, and then it is done correctly by an experienced physician, it would be a good option, especially focal therapy. Again, the essence of success to any focal therapy, whether using HIFU or cryo, is the ultrasound. You got to identify the cancer. You got to make sure that that cancer is the only cancer that one man has. So you can precisely ablate the tissue either by using ice or heat.
Can you tell us about your current clinical trial of cryoimmunotherapy?
I'm very excited with my clinical trial of cryoimmunotherapy. So that means that we knew that all along, based on my own even practice with cryosurgery during the last 10, 15 years, that after cryosurgery, no doubt there is a weak immune response because the damaged cell can be easily identified by your dendritic cells, which is a detective cells that can relay the message to your T cell to become more active killer T cells. Then we know that reaction is there, but it's too weak to rely on clinically. So we've been thinking about how do we boost the reactions by manipulating the cycle a little bit. So our thinking was that combining cryotherapy with the autologous dendritic cells, that means we're using your own dendritic cell and multiplied by millions in the laboratory and introduce that many detectives in the field. That means we inject the cultured dendritic cells into the cancerous area that's once frozen, just frozen. That means that because of they expose many extensive cancer-related antigen, your dendritic cell, millions of armies gonna go and pick up the information, and then bring all the information to your T cell, become activated killer T cells. So hopefully, by doing so, your immune system is boosted, and then that killer cell will destroy your cancer cells where it is remaining in the prostate, or in the lymph node, or in the bones. That would be our we are hoping that our concept is right, and hopefully that you could produce exciting result in the future.